called Judy Chumwire. I'm a midwife and a NICU nurse working with Mulago Specialized and Neonatal Hospital. For this very session, we are glad that each one of us is going to be co-opted in a movement of every heartbeat, a chance to thrive. So, as the organization and as the team that really has looked into these trainings, we want to improve knowledge and skills for all health providers that we have within the facility, those that are in direct contact with the newborns, sick newborns, and small babies. So you're most welcome, and we'll be calling you for other consecutive trainings. With me are the experts, and I'm going to give an opportunity to each one of them introduce themselves and then know who we have in the house. Thank you.
Thank you very much, everyone that has logged on this afternoon. Very welcome to this webinar. I want to also add my voice to Sister Judith's voice to appreciate everybody that has tuned in, but also in a special way to Seed Global and Ministry of Health for coming up with this activity. Very important topic, which as a country we need to be moving to. My name is Dr. Loina Hanga. I'm a pediatrician, neonatologist at Kawempe National Referral Hospital. Thank you.
Hello, good afternoon, everybody. My name is Phenoma Sophie, nursing officer in Mulago Specialized Women and Neonatal Hospital. I'm a senior midwife, and I'm glad to see that you have logged in for this session, very important session. I'm glad for Seed Global and Ministry of Health for this initiative to see that every baby born survive. Thank you very much. I hope you enjoy this session.
Good afternoon, everyone. I'm Dr. Stephen Lauro. I'm a resident of Pediatrics and Child Health in Barara University. Thank you.
Thank you very much. I want us to go through our agenda today, and then after I've done that, we will have the opening remarks by our commissioner, and then we dash into the session. So we are done with the introduction session. We are going to do a quick test. We shall have that, and we shall have the expectations. So okay. So ladies and gentlemen, once again, allow me invite one of the main speakers who is online. Dr. Amina, can you please introduce yourself? Dr. Amina, are you on?
Hello. Yes, I am on. I was struggling to unmute. Thank you so much. Thank you, Judith. And I would like to extend my special thanks to Seed Global and the Ministry of Health. And I would also like to welcome my co-presenters, the experts present on the panel, and also to welcome everyone who has joined in. That we hope this session will bring us insights that will help us to save those newborns. Every life matters. Thank you so much. My name is Dr. Najemba Amina. I'm a consultant gynecologist at Kawempe National Referral Hospital. Thank you.
Thank you so much, Amina. And so our agenda is we are going to have a pre-test and we shall have a session of expectations. Please go ahead and feel free to type in the chat. We shall be seeing the expectations and they will be recorded. We shall have a patient case presentation and then the reactions. We shall have intrapartum surveillance and resuscitation and tools. And then we shall see the role of a pediatrician, stroke, the neonatologist in management of the mother who has undergone intrapartum resuscitation. Then we shall have sessions of discussion, questions and answers. Then thereafter, we shall do our post test and then we will have to close the session. Thank you very much. And at this time, I would love to invite our commissioner to give the opening remarks. Okay. So we will be informed as soon as the commissioner is in and he will give his remarks at any point he comes in. So allow me take us direct to Dr. Ra. So friends, we are going to shoot into the pre-test first. And as I said, let us have your expectations in the chat. So over to you, Andy. First for us, the pre-test. So as everyone is doing your pre-test, feel free if you have to unmute and share with us anything you feel like you want to share with us. You have a question, you have anything burning in as regard to this presentation. You can unmute and then you talk to us. But remember to complete the pre-test. Thank you. Okay, I'm seeing the expectations flowing in. Thank you, Anita. You are saying you expect to learn intrauterine asphyxia management. I can see Patronella saying, I expect to learn more about resuscitation and intrapartum. And this is good. I can see Edison saying, I expect to learn intrauterine resuscitation skills and asphyxia management. Thank you. Let the expectations keep flowing in. Okay, so thank you, colleagues, for the pre-test. We are seeing a good progress with the pre-tests. Now, allow me drive us into the case presentation by Dr. Stephen. Dr. Stephen, you're most welcome, and over to you.
Good afternoon. Good afternoon, everyone. I'm called Dr. Stephen Laura, and I'm the one going to take us through the test presentation. So this is a patient who was in Mbarara Regional Referral. So I'm going to give us the main details about this patient. So this is the baby of MM, who at time of admission was a 2 days old boy. The mother is from the Sinjuru district, and she's the next of him. She was a referral, the baby was a referral from Roy Kubo Health Center 4. The date of birth was 5th of April, 2025, around 11:20 p.m. And the time of admission in Mbarara Regional Referral was 5th April, 2025. And the time of admission was 8 a.m. in the morning. Next slide, please. So the mother is MM. She's a 38-year-old para 2+1. She's married, and her last normal menstrual period was 4th of July, 2024. And so the weeks of amenorrhea by the time of birth was 37 weeks. The presenting complaint of the child was difficulty in breathing, which started immediately after giving birth, and also inability to breastfeed, which started immediately following birth. So this child is 2 days old, delivered by emergency cesarean section at 37 weeks of amenorrhea, sorry for that, due to prolonged labor and one previous cow, which was old, more than 3 years. The birth weight was 3.1 kilogram. The reported ABGAS score from referral site was 5 at 1 minute and 7 at 5 minutes. The mother, however, reported that the baby never cried and required resuscitation, though she was not able to see exactly what was happening because of the operation that was still going on. The baby was put on oxygen therapy immediately following birth. The baby was delivered, as I've said, by emergency cesarean section. It was a prolonged labor that lasted more than 24 hours without any progress. We could not get details of the pathograph from the referral site, and attempts to get that, they couldn't trace the file from the labor ward. The decision to make the cesarean section was done after realization of face presentation following a vaginal examination. So the baby was delivered and later referred to Mbarara Regional Referral due to the difficulty in breathing. So on admission, the child had worsening difficulty in breathing from the time of birth up to the time of admission, with a labored breathing and very fast breathing, with episodes of baby stopping to breathe, requiring a few minutes of resuscitation in the admission room. The baby could not also breastfeed and had very little active movements. So 2 hours following the admission, the baby developed generalized convulsions. However, there were no fevers. In the rebuild system, the baby had bruises on the face with a mild edema or swelling of the face. The baby passed meconium a few hours after birth, and the urine was normal. There was no vomiting or abdominal distension. There were no yellowing of eyes and no any bleeding from any bite. Antenatally, this mother planned this pregnancy, and she attended antenatal care 5 times. The first booking was at first month of pregnancy. The tests which were done, HIV, syphilis, hepatitis B, were all negative. As mentioned earlier, she's a para 2+1. And she received the routine medications of fetal and folic acid, but she didn't get the tetanus toxoid on that antenatal care. And there was no any evidence of any antenatal ultrasound done. And apart from that, the mother didn't have any event during the antenatal. Perinatally, the labor was prolonged more than 24 hours without any progress, according to the story we got. And the membranes were ruptured less than 12 hours before delivery, and it was clear in color. The child had a first presentation, which was discovered later on VE, because the labor was not progressing, and so they found that it was actually a first presentation. So the emergency cesarean section was done because of that. And the mother notably also had one previous car, which was more than 3 years. The birth weight was 3.1 kilograms, and the ABGA score, which was reported, was 5 to 7. And that was conflicting with the mother's story of the child never cried and other things that the mother told us, as mentioned earlier. And there was need for oxygen therapy, and as we said, the baby was not able to breastfeed. First obstetric history, the mother was para 2+1. The first pregnancy, the baby is now 3 years and 9 months old, healthy girl, who was delivered also by emergency cesarean section due to big baby. And there was poor progress of labor on that first pregnancy as well. The second pregnancy was ended up in a miscarriage, which the reasons were not so clear. The family history, this mother is married to a supportive husband and they live together. There are no any other chronic illnesses in the family. So on examination of this child, the vitals, the temperature was 37.0, which was normal. The respiratory rate was 70 cycles per minute, which was high. The pulse rate was also high at 165 beats per minute. And the SpO2 was also very low at 70% in room air, but it improved on giving oxygen up to 93%. The child was sick-looking and floppy or febrile, but there was no pallor or jaundice, and there was no lower limb edema. There was no other dysmorphic features. The child had bruises on the face with mild edema. However, there was no any active bleeding from the bruises. The respiratory system, the child had labored breathing with severe chest indrawing, intercostal and subcostal fixation. However, there was equal air entry. Bilaterally, there were no crackles or wheezes. The central nervous system, the child had a normal head size with a head circumference of 6.9 centimeters. The fontanelles were normal, they were not bulging, and they had reduced, the child had reduced movement in all the limbs, and the cry was very weak and poor primitive reflexes. That's the moral and the grasp reflexes. The child was also hypotonic with no active convulsions by the time of examination. No, there were no sucking reflexes. The pupils were 2 millimeters and reactive sluggishness to light. More light on the convulsion. The child had a convulsion once 2 hours after being received in the regional referral, and it was managed and it didn't repeat. Abdomen, the abdomen was normally full, and there was the umbilical stump was clean, and the abdomen was generally soft with non-tender, no distensions. The anal orifices were patent with meconium stain around, and the genitalia were normal. The CBS, the child had warm extremities. The cup refill time was 1 second. He had a rapid pulse, which we said earlier on, 165 beats per minute, but full volume, and normal heart sounds without any murmurs. The other systems were really unremarkable. So we had an impression of birth asphyxia with HIE3, so seeing the signs and symptoms, especially in the CNS, hypotonia, convulsions, inability to breastfeed, and also the poor oral reflexes. Then we had also a thought of neonatal sepsis because of the difficulty in breathing, though there are no any non-risk factors for neonatal sepsis. So this child was started on management. We started the child on IV D10. Then we started also IV antibiotics, which were ampicillin and gentamicin. Previous slide. Previous slide. Previous. This was slow. Yeah, so we sorry for that. The child was put on oxygen therapy. We gave phenobarbital, loading dose and maintenance, 15 per kg, and then 7.5 per kg. And then dextrose were given for the first 2 days, and then we changed to neonatal fluid thereafter. And then the patients were counseled about the condition of the child, and they were told what to expect in the next few days. The child kept getting apneic episodes, so every time the child got an apneic episode, we did ventilation using bag and mask. So in the follow-up of this child, the difficulty in breathing kept improving, but child developed aspiration at a point when we started NG tube feeds, which was being managed. The child still, by the time of 3 days before, was still desaturating off oxygen. Today is much better, and they are planning for discharge. The child still had hypotonia and weak breastfeeding, though improving slowly, still with a weak cry, though better than before. The family was counseled because at the point they were tired and they wanted to go, yet the child was still on oxygen. So they counseled the child on the prognosis, and the mother and the father on prognosis and possibility of disabilities later. And they agreed on the management that was still being there, and they agreed to stay. The child was also started on physiotherapy to prevent further and to improve the outcomes later. Thank you.
Thank you very much, Dr. Stephen, for the first presentation. We already have some questions in the chat, and we have someone in the chat trying to answer a few questions, but these particular ones, since it is a case study, Dr. Stephen will be able to answer. So the first question is saying previously, big baby, and there was no third trimester scan done in this pregnancy, but we are able to do emergency section. I think this one was supplementing. And then someone is asking, how was the blood sugar for the baby? And someone is also asking CRP, CBC, and RBS. So, and then the other one is saying, well done. So kindly answer these three questions.
The blood sugars were normal, ranging from 3.5 to 5.5. There are no any other issues apart from other questions.
So they are asking, was there any CRP, CBC, and RBS done?
Yes, they were done. Sorry, I didn't put them in the slides, and they were all normal, really.
Okay, then they are also saying, what investigations were done during the management of this baby?
The CBCs were done. We monitored the blood sugars. They were at a point we took blood cultures, though the results delayed to come out by the time of presenting. I didn't have the culture results, though the blood cultures were taken off, and we are awaiting the culture and sensitivity results. So mainly the investigations that were done.
Okay. Thank you, Doctor. Someone is saying to take us through how to prepare neonatal fluids. Dr. Stephen is an obstetrician, so probably someone is going to answer you in the chat. Thank you. Okay, so someone is also asking why neonatal sepsis?
Let's proceed with the next presentation. Let's proceed with the next.
So thank you so much for the questions that are flowing in, and keep them flowing in. We shall get answers in the chat. We have experts giving answers in the chat. Allow me, I invite Dr. Najemba Amina to take us through the intrapartum surveillance and resuscitation.
Thank you, Judith. May I please share the screen? A moment, please. Yes, as I'm enlarging the screen, my name is Dr. Najemba, as earlier introduced. Thank you, Dr. Lauro, for that case. And it brings an insight on our intrapartum care, because this mother was in labor for 24 hours. And it is at the epitome, or at the end, at the tail end, when the malpresentation, the malpresentation was actually noted. So it shows a lot about our intrapartum care, both for us, the doctors and the midwives. So ideally, this kind of presentation should have been identified early, and probably would have had a better outcome from this baby. Thank you so much. For this session, I'll be taking you through antepartum, intrapartum surveillance, and diving into the initial intrauterine resuscitation for such babies whom you have features that are showing you features of pathological tracings on monitors or on monitoring. So our antenatal fetal surveillance basically refers to ongoing monitoring of these fetuses during pregnancy. This is done mainly after 28 weeks. We want to be able to identify and address those risk factors that predispose or put these babies at risk of fetal death or fetal distress. So you'll find a COG recommending at 36 weeks, at 32 weeks, at 36 weeks, or at 39 weeks of gestation. I need to emphasize that this should be a shared decision-making between the clinician and the client, because it has a number of impacts. It has cost implications. It has iatrogenic implications, where we have sometimes to force a decision or to counsel the parents about preterm delivery and its possible complications, as will be elucidated on by Dr. Loy. So this is important to be a joint decision. And these methods that we use should be really tailored to the individual. It means you need...
Amina, please, would you put the presentation in the slideshow?
Oh, sorry.
Thank you.
Sorry about that. Are we there? This is okay? Hello? Am I audible enough?
Yes, and this is okay. Thank you, Amina.
Oh, thank you so much. So I was saying the methods we use need to be tailored depending on the mother and depending on the potential complications that the mother has. Okay, so that we weigh between the costs, the healthcare costs, and also the iatrogenic implications that may have on the baby and the couple. Okay, and we need to look at the other clinical factors that may potentially affect our antenatal fetal surveillance. Okay, for example, if a mother is admitted because of high blood pressures and you're giving this mother magnesium sulfate, you're giving this mother corticosteroids, these can actually have effects or can affect our tracings on our antenatal fetal surveillance methods. So what is the objective of antenatal fetal surveillance? We want to mitigate the risk of stillbirth. This is especially so for those mothers that we identify as high risk, mothers with the diabetes, can be GDM, mothers with preeclampsia, or those that are complicated by issues such as intrauterine growth restriction. So we do not, it may not apply routinely on every mother, especially the low risk mother, but it is at the point that you get to determine that this is a low risk mother and this is a high-risk mother. What are the indications? The indications can be maternal, can be fetal, or they can be obstetric indications for antenatal fetal surveillance. So I've already said any mother with any chronic hypertensive, a chronic condition, could be hypertension, could be gestation, could be diabetes mellitus, could be sickle cell, especially mothers who are sickle cell disease patients, those with chronic renal disease, mothers with advanced age. These are categories of mothers whom we should offer antenatal fetal surveillance. Fetal factors, we look at babies whom we are suspecting of growth restriction. For example, a mother comes for review, you assess her, you find her gestation, her fundal height less than her gestation age. Probably she also has some other maternal risk factors. These are mothers that you offer these antenatal fetal surveillance methods. Multiple gestation, fetal anomalies, and mothers who complain of reduced fetal movements. Obstetric factors, if you have a mother in antenatal clinic and she comes with this history of poor outcomes in the previous pregnancies. For example, she tells you, my first pregnancy was an EUFD, so delivered as a macerated stillbirth, or she tells you, I was told I had the features of IUGR in the previous pregnancies, or I had preeclampsia. These are mothers that we should really offer antenatal fetal surveillance. Previous history of postpartum pregnancies, mothers with oligohydromios, especially that oligohydromios that is not from drainage. And you do an ultrasound scan incidentally, and it shows evidence of reduced amniotic fluid volume. These ones should be offered antenatal fetal surveillance. So what do we use for antenatal fetal surveillance? These are the equipments that you'll see us using. External fetal monitor, we normally call this a CTG, and this measures the fetal heart rate vis-a-vis the uterine contractions. Oxytocin is sometimes employed when we are doing a contraction stimulation test. A vibroacoustic stimulator, this one helps us to induce fetal movements when we're doing a non-stress test. So we use a vibroacoustic stimulator. And of course, the ultrasound scan, which does for us several other things, but among them, especially one with a Doppler velocimetry, so that we can do biophysical profile, we can do modified biophysical profile, and we are able to do umbilical and middle cerebral artery Doppler velocimetries. So what are the techniques? The techniques we have are maternal perception of fetal movements, the non-stress test, the contraction stimulation test, the biophysical profile, modified biophysical profile, and umbilical Doppler velocimetries. These are the ones that we commonly use in antenatal fetal surveillance. Of course, there are other routine obstetric scans, but these are the ones that will tell us about fetal well-being, whether we have any evidence of fetal placental pathology or fetal hypoxia. So the movements, a mother should be able to detect about 10 movements when she lies down for about 2 hours. But these may be even detected within 21 minutes. So when she lies, this is what we do when we tell these mothers to go home and monitor fetal movements. You tell her, at least if you are able to see, to feel 5 movements in an hour, that is at least good enough. 10 movements within 2 hours, that's good enough. And when you feel that your fetal movements are reducing, or you spend an hour and you've hardly felt your baby, this we've already seen that this is a predictor of a poor fetal outcome or IUFD. So even studies have confirmed really fetal movements to be more predictive of adverse fetal outcomes. So non-stress tests, these are the ones I said we use, we monitor the fetal heart rate by using external fetal abdominal transducers, basically set for 20 minutes. So what are we looking for here in this case? Sometimes we use a tocodynamometer. This one helps us to induce the fetal movements. So on this tracer, we look for variability. We look for any fluctuations in the baseline fetal heart. We look for any decelerations, and we shall describe it as normal or reactive if we have accelerations. And what do I mean here? If I have a baseline, the fetal heart accelerations, that is about 2 of them, going to about 15 beats per minute within 15 seconds. This one shows that this is a good parameter. This is a normal finding. Or if we have moderate variability with an amplitude of about 6 to 25 beats per minute within 2 minutes. This also gives good evidence that you have a good fetal placental saturation and therefore fetal oxygenation. So, but non-reactive, if we have fetal decelerations, we define that as a non-reactive, non-stress test. If we don't have sufficient accelerations, and if we have decelerations when you monitor the fetal heart rate for about 2 minutes, and it shows you a fetal deceleration, this will confirm to you that you have a non-reactive non-stress test. Okay. So if you do this within 20 minutes and you have those kind of decelerations, or if you have one deceleration or a prolonged deceleration lasting more than a minute, so 2 minutes and above, will show you that this is a non-reactive non-stress test. So when we have a non-reactive and non-stress test, then we proceed doing a contraction stimulation test. So in a contraction stimulation test, this is performed basically in patients. We want to identify compromised fetal oxygenation, okay, by looking at the fetal heart rate vis-a-vis uterine contractions. Okay, so these are recorded at the same time. If you have insufficient contractions, here you may, like I said earlier, you may give IV oxytocin. But please don't do contraction stimulation tests if you don't anticipate vaginal delivery for this mother. If she has contraindications to vaginal delivery, then please don't do a contraction stimulation test. The picture here just shows you, well, this is what we do. These are connected to the electronic fetal monitor or the CTG, and this records the maternal contraction vis-a-vis the fetal heart rate. So we said we can have it negative by if we don't have any of those decelerations, that is a normal one, and we can have it positive if we have late decelerations. And it can be suspicious. In suspicious, you have those intermittent late decelerations, and then it can also be equivocal where you have your fetal heart decelerations more than 2 minutes. So these last two are not desirable. Okay, the last three are not desirable. They show a non-reassuring fetal state. And this may mean that you need to do further tests like a biophysical profile or doing a Doppler, an umbilical Doppler velocimetry studies. So this picture just shows you a contraction stimulation test using a CTG tracing. So you have down here, the tracing shows maternal contractions, and up there you see fetal heart rate. And this tracing is abnormal because these are showing late deceleration. You see at the peak of the maternal uterine contraction, you get the nadir of the fetal heart rate. The deceleration is happening after the contraction. In a normal non-stress test, you have the peak of the contraction coinciding with the nadir of the fetal heart rate. And the nadir is this trough that I am talking about, coinciding with the peak of the fetal heart rate. You know that that is acceptable and that's normal. But when it comes after a contraction, when you see such a tracing, then you realize that this is a pathological tracing and therefore needs interventions. This is just further illustrations showing you what I'm just describing. You have early decelerations. These ones actually normally during a contraction, for example, from head compression during labor. If you have your insufficiencies where you uteroplacenta insufficiency, this is mainly where you have pathological, okay, with the late decelerations. And then variable, which can happen in intermittent cord compression, for example, in oligohydramnios. So then you get to have variable decelerations. So that was a contraction stimulation test. The next antenatal fetal surveillance method is a biophysical profile. And we shall be very happy when you give us a biophysical profile of 8 to 10 or 8 and 10. These are normally show that these are normal cord pH and there is good fetal oxygenation. However, if you have lower, like we shall see, then you need to be concerned. So the biophysical profile combines 5 components. It has a reactive non-stress test. It has fetal breathing movements. It has fetal movements. It has fetal tone, and it has amniotic fluid volume. So for the fetal breathing movements, if you observe one cycle of fetal breathing, and this is happening more than 30 seconds or more, this is considered within 30 seconds, this is considered acceptable. If it is less than that, then it is not a desirable outcome. We should be able to see at least one cycle of fetal breathing. Fetal movements, we want at least 3. So 3 or more are desirable within 30 minutes. So this fetal breathing, these tests of biophysical profile are within 30 minutes. Even the breathing that we're talking about within 30 seconds should be happening within a spectrum of 30 minutes, okay? The fetal tone, at least you should be able to see one extension or one flexion or a baby flexing or opening their hand on ultrasound scan within 30 minutes. And that gives you that is a good, we score it too when we see such observation. Amniotic fluid volume, if you have a deepest pool of 2 to 8 centimeters, this is given a score of 2. This is acceptable. So that gives us the total of 10 out of 10. So each of these ones in the descriptions that I have mentioned is weighed against 2. So if you have the full description, that is 2, 2, 2 at the end of the day, okay? So if you have a biophysical profile of 6, this is considered equivocal, especially if the pregnancy is less than 37 weeks. It's a preterm pregnancy. Here we advise that you recheck this biophysical profile within 24 hours. However, if the pregnancy is the term pregnancy, and you're already getting an equivocal biophysical profile, then please, by all means, go ahead and deliver this mother, because the outcomes, if you give the mother more time, may lead to worsening fetal hypoxia. For those that, if you get, for example, 4 out of 10, and this pregnancy is started 2 weeks of gestation or more, delivery is recommended also for these patients. This is a compromised or a suboptimal biophysical profile, same as 2. Delivery is recommended in most of these cases. The modified biophysical profile looks at only 2 parameters. It looks at the non-stress test, okay? It should be reactive, and also looks at the amniotic fluid volume, which should be above 2 centimeters, the deepest vertical pool. So if these are positive, this will be pronounced as a normal modified biophysical profile. However, if it is negative, then you should go ahead and do a contraction stimulation test and and do a full biophysical profile. The other test that we employ, or modality that we employ in pregnancies that we deem high risk, is by doing uterine artery Doppler velocimetries and middle cerebral artery Doppler velocimetries. This is not for every pregnancy, not for low-risk pregnancies, but should be employed in pregnancies that are complicated. For example, diabetic preeclampsia, sicklers, or our sickle cell disease patients. And those are pregnancies that you have, for example, the scan identified features of intrauterine growth restriction. So you want to do Doppler artery velocimetry on this to analyze the vesicular resistance by looking at the waveforms. So it is done in addition to those other profiles. Ideally, as pregnancy progresses, the vesicular resistance, the umbilical vesicular resistance should be it should be going down. That is the normal physiological trend. It should be reducing to allow enough flow to the fetus. Okay. However, in compromised fetuses or pregnancies, you have an increase in umbilical vesicular resistance, and at the end of the day, increase the reduced blood flow to the fetus. So for me as a clinician, it is very important, and for all of us, to look at, I always urge my residents to look at the tracing itself, because without you looking at the PIs and resistivity index and try to remember, where does this fall? Is it abnormal or normal? When you look at the tracing, it immediately tells you that this is an abnormal tracing or an abnormal waveform showing a compromised fetus or not. So if you see absent, or if you see a reversed end diastolic flow, the Doppler velocimetry wave, this will indicate fetal compromise, and therefore chances of increased perinatal mortality and morbidity are increased in this case. So in this case, you saw this. So as a clinician, you should be able to act, and you should use multiple waveforms. No, don't depend on only a small section, but use multiple to make your. Hello? Yes, please. Oh, I thought I had yes, so this tracing here that we see is of a Doppler artery velocimetry that we use in antenatal fetal surveillance. So when you look at this tracing here, you can see the peak up here is the peak systolic velocity. And then down here, you see the end diastolic velocity. So this is normally what we use. If we see the end diastolic velocity at the baseline, where you see that line at the base, then we know that this fetus is compromised. Or if we see the waveform crossing that baseline, so if it is at the baseline, we say there is no end diastolic flow or velocity. If we see it crossing the baseline, then we shall say there is a reversed end diastolic velocity. This is,
Amina, please. Dr. Amina?
sorry? Yes, please.
I'm reminding you that we are having 15 minutes left.
Okay.
So try to speed that, please. Thank you.
Okay, so this is basically what I was trying to demonstrate, that when we are looking at umbilical Doppler velocimetries, these are the things that you look for. You see a normal one for a normal pregnancy, for a reduced end diastolic flow, you see that. At absent end diastolic flow, you see such a wave. Always ask the radiographers for these when you send them for Doppler studies for these tracings. Now, interestingly, what happens to the umbilical artery during these studies is the opposite of what happens to the middle cerebral artery. So in the middle cerebral artery, the reverse happens. You have decreased resistance when the fetus is compromised because the fetus is trying to send all the blood flow now to the brain, okay? So what you get to see is you get to see a high PI, a high end diastolic velocity compared to the umbilical artery Doppler velocimetry. So those are the different surveillance methods that we use in antenatal. And like I said, these can have several implications on the mother. We need to be cognizant of them. Costs, anxiety to the mothers, false negative results, especially for some of the modalities. We know sometimes fetal kicks depend so much on the mother. So sometimes if you do a iatrogenic preterm delivery and the mother was not very careful, you may end up causing preterm labor who ends up scoring very well. Even false positive results can come from it at the same time. So intrapartum fetal monitoring, I know our next presenter is also going to hint about it. But the purpose here is mainly to monitor the fetal heart rate during labor to evaluate fetal oxygenation. We know in labor, there are several things that can happen. For example, mothers can come in with tachysystole, which can be from normal labor or from local hubs, or it can come from our own iatrogenic interventions. For example, when we do induction of labor with oxytocin. So when we are monitoring these mothers, especially with the electronic fetal monitoring, that is a CTG, you are able to identify that this fetus is getting compromised. We are getting late decelerations. We are getting variable decelerations that are marked, and these are pathological, and therefore you need to intervene. There are other modalities of doing intrapartum fetal monitoring other than EMF, electronic fetal monitoring. For example, intermittent using the PNAD fetoscope. And there are other methods that are becoming a bit obsolete because they are hardly used, like the fetal scalp sampling or fetal scalp electrode or NST. So those ones, we rarely get to use them. And if you look at literature, it will not highly recommend them. But commonly what we are using is electronic fetal monitoring, and we are using intermittent fetal monitoring using a PNAD fetoscope. This is just to take you into classification of fetal heart tracings, which came up after consensus in 2008. And this is when you say this is a category 1 fetal heart rate tracing, where if it is category 1, you know this is normal. If someone tells you we have a category 1 fetal heart tracing, you know this is normal. Accelerations, moderate decelerations, okay? Or early decelerations. Category 2 are there, equivocal. And then category 3, these are really pathological, where you have the late decelerations. So management of those tracings really depend on the category. If it's category 1, then you're going to go ahead and continue the routine follow-up of a mother who is in labor, meaning in first stage, every 30 minutes, monitor this fetal heart rate. And if you are in second stage, every 15 minutes, monitor the baby's fetal heart rate. Okay, but where you have non-reassuring fetal heart rates, that's category 2, and the category 3. Then you need to also do 2 things. First of all, reassess and see, do you have any reversible causes? For example, maternal hypertension, for example, cord compression from oligohydramnios, for example, tachycystole, those ones that you need to intervene on, okay? I will look for irreversible causes, for example, cord prolapse or uterine rupture for the other group, okay? But like I said earlier, have caution when you are using medications like magnesium sulfate, corticosteroids. These can have effect on your electronic fetal monitoring. So why do we do resuscitation intrauterine? We want to improve fetal oxygenation through the different mechanisms. Okay, we want to reduce the hypoxia, the fetal hypoxia and acidosis that we see in babies who are distressed or in fetal distress. So just running through them, we have maternal reposition. And I know this came up in the chat as the majority of expectation, but I know we even practice this commonly in our labor suits. Maternal reposition, change the mother to the left lateral position, hydrate this mother with 1 liter of crystalloid, okay? And that is normal saline or Ringer's lactate. Discontinue uterotonics or decrease uterotonics. So if the mother was on inducing drugs, labor-inducing drugs, stop the oxytocin. Go down there. If you put a misoprostol, remove whatever remnant is remaining there. But these tend normally not to, well, the immediate cessation of contraction does not come immediately. So normally this takes about 45 minutes where you start seeing a decrease in the contractions. So you may need to use adjuvant tocolytic drugs, for example, nitroglycerin, tabutalin, preferably nitroglycerin because of its less maternal side effects. Oxygen administration, we have seen it improving the fetal outcomes or the fetal saturations. But it also has a lot of controversies if you look at literature, with some studies bringing out some deleterious effects from hyperoxygenation of the mother, both to the mother and the fetus, looking at it in the context of free radical and its effects. So there is a recommendation that if we are to give oxygen therapy, then it should be in the context that we have pathological tracings. That's category 3 or category 2 tracings. And this should also, there should be cases of, all cases of maternal hypoxia. And when we are giving it, preferably we don't exceed 30 minutes of oxygen therapy. Maternal hypertension, I said if the crystalloids do not improve the blood pressure, then you need to consider vasopressors for this mother, like giving them phenylephrine or ephedrine to improve the hypertension. If the mother is on epidural analgesia, then you need to inform anesthetist to come and intervene in that case, all right? Amnio infusion, limited evidence, but it has been shown to improve on the decelerations on the fetal heart tracing. Though long-term and short-term neonatal effects, these have not come out strongly. So we still hope to see more evidence about amnio infusion. So if we have seen pathological tracings, so then we need to make a quick decision to deliver this mother. And the cesarean section, we have to define the time interval. There is the diagnosing fetal distress, and then you do a cesarean section 1 hour later, 2 hours later. This has gone beyond the recommended time. Of course, the scientific studies evidence are not so much to give us the sufficient threshold, but at least it's agreed an arbitrary standard that it should not be beyond 30 minutes once you have made a decision to incision interval. Thank you so much. I think I tried to rush a bit, but I hope I've been able to deliver the message home. So my concluding remarks are summarized in this picture. And it takes me back to the case that Dr. Lauro presented of this woman who has carried a pregnancy for 9 months. And at the end of the day, you are giving her a baby who is either an FSB or a baby who is going to be a vegetable. So it draws us back to go back and with this message that when we are taking care of these mothers in the antenatal and intrapartum period, we be cognizant of those risk factors or telltale signs that we should go ahead and take these mothers into targeted fetal surveillance. And of course, during labor, to give them time and monitor labor. Labor monitoring comes back to be the key. Because even if you put an electronic fetal monitor, a CTG on a mother, and then you walk away, you don't come to interpret it and address the abnormalities that you see there, then you are bound to get a poor outcome. This has a lot of implications, social implications, psychological implications, marital implications. So yes, ladies and gentlemen, I come to the end of my presentation. Thank you so much. Back to you, moderator.
To the next presentation.
Okay, thank you very much, Dr. Amina, and people have gathered flowers for you. Thank you for that extensive presentation. You may go to the chat, and other experts are joining you to answer the questions that we have in the chat. Thank you very much. Now let's welcome Sister Chinomhanji Salfin to give us the roles of a midwife or a nurse in intrapartum resuscitation and tools. Thank you. Over to you.
Thank you very much, Judith, the moderator. Thank you very much all the presenters and the audience present. I'm Philomena Salfin, senior midwife, and my job has been made easier by Dr. Amina's presentation. And I'll go through very fast. Can I have the first slide? First slide. So I have this introduction here that intrauterine resuscitation is a set of procedures implemented during labor when a non-reassuring fetal heart rate pattern with fetal hypoxia or acidosis. And the hypoxia, we say lack of oxygen in the fetal blood, and acidosis, accumulation of acid in the fetal blood, which is very dangerous to the baby, that would lead to the fetal death or severe birth asphyxia. The fetal heart rate is considered non-reassuring as a midwife if you are in labor monitoring, if there is absence of variability and high frequency and increase the depth of deceleration. If you are keen in Dr. Amina's presentation, she explained very well the depth of decelerations, variability, and high frequency. The high frequency is when you have tachycardia. The tachycardia that is not resolving. As a midwife in labor, you must be very keen. And that's the midwife that will detect that if you have been having zero separation in the labor ward, not to walk away and come back right after 4 hours. A non-reassuring fetal heart is considered an emergency, and therefore action should be thought of timely and prevent birth asphyxia that has contributed to the high numbers in neonatal death. Yes. So according to the study, this study was done in the northern Uganda. The incidence of non-reassuring fetal heart was around 15.1, and that was done by Elizabeth Ayebari. 15.1, dear midwife, is too much to a mother who wishes to have a live baby and go home very happy, and we should not meet her in the neuro clinic or in the physiotherapy unit. And whenever you meet such babies as a midwife and you find you're the one who delivered this baby, really we must feel guilty. Therefore, every caregiver, whether midwife or doctor, must commit to monitor labor progress religiously. I'm putting that word religiously, intentionally, and be able to detect any deviation from normal and act immediately for better outcome. I'm sure Dr. Roro's presentation, this midwife was monitoring this baby that was born and scored 5, prolonged labor for 24 hours. There was no that word religiously. This midwife must have abandoned the mom in labor, and she had decelerations for over and over, and it was too late, and we had to get that morbidity for the baby. Therefore, the goal of intrauterine fetal heart resuscitation is to improve oxygen delivery to the placenta and maintain umbilical blood flow, potentially reversing that fetal distress that you have detected. So the risk factors to a non-reassuring fetal heart rate in labor, Dr. Anna has highlighted every condition and pattern. A midwife in antenatal, those mothers, our dear mothers that come in antenatal, kindly midwives, you are eye openers to the doctors. Take history, assess the mothers, and forward them to the doctors for further assessments so that we should not lose these babies and come to labor ward when they have intrauterine fetal death. The risk is down there, and Dr. Amina has already elaborated on that. Next. Intrapartum, you are in labor, you are going to admit this mom, you find there is meconium stain, or along the way you are monitoring the mom, and you rupture membranes, or they rupture themselves spontaneously, get a meconium stain. This is the baby that is showing to you that there is danger ahead, and you must consistently monitor. If there is presence of tachysystole is hypertonic contractions. We have seen them, either the mom is on oxytocin or even she has taken local herbs. We have registered a number of women in labor that take herbs. Dear midwives, when you are in labor suit, in any form of the suit you are in, kindly probe to these mothers about the local herbs. It is increasingly the highest percentage of moms have local herbs. You think you are monitoring, and the mother is taking the local herbs that will divert the fetal heart rate, and we get the death in the process of monitoring. If there are signs and symptoms of intrauterine infection, chorionitis, take note of that and monitor this mother. Unexplained vaginal bleeding can be a blood show, it can be placenta previa. That is a sure deal. You don't need to wait anymore. This is the mother that needs to be delivered very fast. This fetal heart is not going to change. The use of oxytocins, you are in labor, the doctor has said, adjuvant labor. Don't say the doctor has said, but for you, you are the monitor, you are the eye to the doctor. Please make an alarm to the doctor that yes, I began oxytocin, but I'm seeing deviation from normal. And if therefore I've stopped oxytocin, you can come and review. Next slide. Labor monitoring involves using various tools and devices to trace the progress of labor and assess the well-being of both mother and the baby. In labor, we use the pantograph as a tool. Midwives in this session kindly use that pantograph. Don't fill the pantograph retrospectively. We have seen them. You begin the pantograph and just you forget it. Then you begin plotting after delivery. I want to assure you will never capture any deviation from the fetus or the mother. You have seen that picture aside. That lady, that nurse is listening to the fetal heart with a peanut, but you can check how is comparing the fetal heart compared to the maternal pulse, where we have always gone wrong. We don't feel for the maternal pulse. We get 80 beats per minute, 90 beats per minute, we make an alarm to the doctor. I have bradycardia here, doctor. Please, this mother needs a cesarean section. And because poor doctor who is very busy in the theater, will just become either say, I am dealing with a PPH in theater. Please prepare that mother and bring. This mother is going to face a knife for nothing. Kindly midwife, compare the maternal pulse with the fetal heart rate. Go back, there is something, yes. Then we have that handheld devices. We have sonocade. We are going to see how they look like. Then the peanut. The sonocade is a bit better because it gives you values directly, but also it will not give you the contractions. You must use your palm to compare the fetal heart rate and the palm, the intensity of the contraction, the tense of the abdominal muscles. And you will feel how the contraction will start, and we have to reach its peak and reduce and compare it with what you are seeing on the sonocade. Next. We have the cardiotocograph, the CTG was mentioned. Those midwives who are present that are in the hard to reach areas that cannot access that CTG, don't get worried. With your peanut, you can also listen. But those who are very lucky in central and in the very good private hospitals, a CTG is a very good monitor. The device uses to continuously record the fetal heart rate and the contractions. You are able to relate the contractions with the fetal heart rate. Dr. Anna explained this better, and those are the birds. Please don't get the probe for the fetal heart, and you press it in a wrong position. For the fetal heart should be lower, as you see that picture, and for the contraction, the total is above at the fundus. That's when you can feel the contraction. Next slide. The monitoring tools and devices, I intended to put them there. You see the peanut, and we have wooden, plastic, and metallic. Don't say they don't record the similar thing. They are the same. Well, the texture matters. So there is no difference between those peanuts, and that is the sonocade, which is better than obviously the peanut, but don't get worried that I cannot monitor because I don't have a sonocade. That's the CTG, which you can even print, but as doctor said, even if you have a CTG and you press it on the mother's abdomen and you walk away, you go to sleep, you go to rest, the decelerations will keep there, then you will come and find even the latest deceleration, and when it has gone over 1 hour, that CTG will be useless. That is the pathograph. According to Dr. Stevens' presentation, I believe the midwife brought it and surpassed the action line. She completed the pathograph. She was not able to interpret. Kind of midwives in this session. If you brought a pathograph, you see a deviation from normal. Kindly report that deviation immediately and be on the neck, I mean the neck of the doctor, to make sure that the action is implemented as very fast, so that your efforts are not frustrated. We have seen midwives plotting the pathograph, making an alarm, but then the doctors, maybe for some reasons, the actions are not implemented, and we end up losing the baby, or we deliver an asphyxiated baby. The midwife becomes distressed like the baby. Next slide. Next slide. So as we go to the abnormal, we need to know the normal. A normal fetal heart rate during labor typically falls between 110 to 160, though other books say up to 170, those ones who have CTGs. A baseline heart rate within this range suggests a normal fetal acid balance status at that time of observation. It is important to remember that the baby's heart rate can naturally fluctuate above or below this range due to either fetal movements or response to contraction. As a midwife in labor, don't get worried, and usually the variation is between 6 to 25 beats per minute and should not exceed 2 minutes. However, if there is lack of variability or presence of deceleration, it could indicate a problem requiring further evaluation or intervention. Next slide. Fetal heart decelerations. This is exactly what Dr. Amina mentioned, and I will not waste the time, but as a midwife in the labor, these decelerations can be picked even when you have a peanut. You see, the other one is a mirror. The fetal heart rate up is reflecting the contraction. As the contraction reaches its peak, then the fetal heart rate goes down to the peak depth of the deceleration. Now, the fetal heart rate goes down as the contraction goes up. That is early deceleration, and we are not worried as midwife. It can be head compression during second stage. You need not to get worried. However, where you get worried is late deceleration, as the Dr. Amina said. Midwives, if you are listening to the fetal heart and you see a contraction, it is at the peak with you in your hands. You feel a contraction at the peak, but then the fetal heart drops after the peak of a contraction. That is the late deceleration. You are good to make an alarm to the doctor that come for help. It is an emergency. We shall see what you do as a midwife before the doctor comes. Next slide. Next slide.
You can apologize for it.
So we apologize. There's a lot of technical problems, but don't worry. So I told you that if you have late decelerations, you need to intervene. We have seen also midwives, when they see those abnormalities, you make a call to the doctor before you do anything. The doctor is not responding, you begin lamenting with the mother. Kindly don't do that. Intrapartum and resuscitation interventions aim to improve oxygenation to the fetus and reduce risk of fetal acidosis when a non-reassuring fetal heart has been detected. So what you do, you have been with this mom in labor. You have been explaining to her the normal. Your baby is okay, but this time you have get a deviation from normal. As a midwife, as a caring midwife, the first thing you should do is to explain to the mother and the caretaker about the changes in the fetal heart rate and the interventions that you're going to do to rectify this problem. So you give the mother reassurance that you're going to do whatever it takes and reverse the distress. So immediately you reposition this mom to the left lateral position, give oxygen, give IV fluids. As a midwife, you can end there. As a midwife, if you can do those three things, repositioning, oxygen, intravenous, then make a call to the doctor. I'm not doing very well. The doctor will come, and if he wants, he does that. However, if you have oxytocin drip as a midwife, don't say the doctor should come and order, stop. You stop it and give brain fluids, and you explain to the doctor as he's coming. Next. All those are explaining those interventions. I will not go through. Dr. Amina has gone through them. Next. Next. We have a nursing mnemonic for a non-reassuring fetal heart as a midwife. Just from that, you will not go wrong. Fetal heart rate pattern, what is the cause and what do you do as a midwife? If you have variable deceleration, what is the cause of that? It is body compression. You can do maternal repositioning. You will get the fetal heart back. Then early deceleration, this can be head compression. What do you do as a midwife? Identify labor progress. Are we in the second stage? Now, if we are in the second stage, we have early decelerations. Can we do assisted delivery on this mom? Or we can do any other thing? So, but that one is not a problem. After you have also repositioned the mom, you can get a good fetal heart. So you don't get worried with early deceleration. Accelerations are okay. They are good as long as they are ranging in the normal range 110 to 160, and there is no intervention as a midwife. Don't worry about those fluctuations. But late deceleration, what does it mean? What is the cause of it? Placental insufficiency, and then it means you execute interventions. So that mnemonic, kindly program it and use it. You will not go wrong as a midwife. You will not be disappointed. Next slide. Multidisciplinary approach. You have got that late deceleration. It is an emergency. What do you do as a midwife? As you have done the other interventions, the three, actually it is the lion. Lion, left lateral position, intravenous fluids, that is proselytes, O is oxygen, and N is notified. So you are notifying here. We use ASPR model framework of reporting. That is communicating clearly and effectively to whoever you are calling, because you can be misunderstood. ASPR is A is attention. Get the team's attention immediately. You can shout for help, it is an emergency, the next midwife will come in. You can ring the bell if you have it, a local bell. You need not to have electrical. So that you get the teams on board. Now, but you must explain the situation as a midwife who has been caring. Briefly state what is happening. You are calling the doctor, but explain what has happened. Hello, doctor, for example. I have a non-reassuring fetal heart, right, with prolonged bradycardia. You have told the doctor the situation. You want the doctor to understand how fast should he do his first steps. Now, B is background. You have said the situation, but give also the background information. For example, I have SK, a prime gravid at 38 weeks in active labor on oxytocin 5 international units, fully dilated. Presenting part is at station 1, no cupped, no molding, molding is grade 1. You can even add that pelvis is adequate. This doctor who is coming comes with a mind, what am I going to do? Next slide. You're even going to tell him what to do. E is evaluation. State your assessment. Measure the fetal heart rate. You say it was bradycardic, 100 beats per minute to 108 for 6 minutes, and no response to my intrauterine resuscitation, as we said in the lion. So R, as a midwife, you have the right, you have the capacity to give a recommendation to this doctor. Clearly state what you want to be done, what should happen, e.g., I recommend assisted vaginal delivery. Remember that the mother was in second stage at station 1, there's no cupped, more in grade 1, pelvis adequate. As a midwife, assisted vaginal delivery, you recommend it. When the doctor comes, may cancel it or will go with it. Document all the proceedings accurately. Next slide. Now, you have called the doctor. As a midwife in the delivery room, kindly be with the resuscitation equipment. Don't run when the baby comes out, is a fragile, score 2, score 3, score 5. Then you are looking for those arm bags, you are looking for the penguin suckers. Get them ready as the doctor is coming because you don't know the mode of delivery. So remember, when you notified that the theater was notified, the theater is also alert, preparing the resuscitation equipment. So the mode of delivery depends on the gestation age, cervical dilatation, as I said, fetal station, and the response to intrauterine fetal resuscitation. Vaginal assisted delivery is preferred if the mother is in second stage and no contraindications. You know those bureaucrats of preparing the theater and whatever, you wasted time and the baby is getting more distressed. Resuscitation equipment should be aligned and functional. Test those equipments before the baby comes out. Cesarean section is indicated if there is persistent non-reassuring fetal heart despite intrauterine resuscitation, as Dr. Amina said. Inform theater to prepare surgical team must be present. All the teams, anesthetic team, obstetrician for her, she will go with the mother, and the nursing team, and be sure that in theater, in labor suits, all of them are skilled in neonatal resuscitation. Next slide. So as we have looked at the monitors, in external monitors, internal monitors, Dr. Amina talked to them about them, internal monitors, that there are advantages and disadvantages of these monitors. The advantages of external monitors, they are less invasive. They are put on the mother's abdomen. The amniotic sac does not have to be ruptured. If you look at the internal monitors, you need to insert them into the vagina on the fetal scalp. They possess little risk to mom or baby, and you can have them removed at any time. But if you have internal monitors, you don't just remove them. Remove them when the baby is going to be delivered. These external monitors allow mom to assume a variety of positions, and if you go to the peanut and saddle cage, the mother can walk around because it is intermittent monitoring, and after monitoring, you tell her to walk around. Exercises in labor is very vital for quickening labor. Some facilities outside there have beds which are free, and they are wireless, so it is telemetry. The mother can move when the monitoring device has been left behind, but we walk, they are wireless, but we are not there in Uganda. In the future, we shall be there. What are the disadvantages? Next. Disadvantages. Let us look at the disadvantages of these external monitors. Next slide. Yes. The external monitors are less accurate. When you look at the internal monitors, which we are not doing here in Uganda, maybe in other facilities, but at a low percentage, the external monitors are less accurate and maybe restrict the maternal movements, and yet you want the exercises in labor. The signals from the units can be easily disrupted if the baby or mom are moving around. So you can lose the signals and maybe may accidentally detect mom's fetal heart and will make an alarm that there is a fetal bradycardia, fetal tachycardia. They are often not effective in obese mothers. If you see our peanut, the peanut, you cannot detect a fetal heart when the mother is obese. Next. Next. Okay. So we have looked at those advantages and disadvantages. IT is trying its best. There's a lot. There's a lot. So we have a conclusion that non-reassuring fetal heart rate patterns are clinical red flags indicating potential fetal hypoxia and acidosis. And management includes the rapid assessment, intrauterine resuscitation measures, and timely delivery if the condition does not improve. The decision on mode of delivery should be based on clinical findings, response to resuscitation efforts, and the urgency of the situation. Multidisciplinary teams and continuous monitoring are essential to optimize both maternal and fetal outcome. With that, I end my presentation with the reference if you want more readings. And I ended with a photo that has a baby smiling. Every mother in labor must smile, and you as a midwife, you have to smile and enjoy life with those families. And you will meet them elsewhere, and you are proud, and you are a proud midwife. Thank you for listening.
Thank you very much, Sister Salvin. And this is really great. Midwives, a lot has been emphasized to you. Please go on and have your comments. Please go on, ask your questions in the chat. Experts will definitely answer. Okay, so allow me now invite our pediatrician, our neonatologist, Sister Southie, is emphasizing multidisciplinary approach. Dr. Lloyd, you are most welcome. So take us through.
Thank you very much once again. Thank you to everyone that has logged on, and it's over an hour since we started. So thank you very much. And again, appreciation to SIG Global for organizing this session. Yeah, the first image there shows why we need to be there. That baby needs to be well, healthy, and needs to thrive. And I have told myself before I ask for the next slide that as long as the baby is not alive, then the mother shall keep coming in. So if we can't give them live babies, then they shall keep coming to ensure they get live babies. And the next time, we don't know if they shall leave the unit or the hospital alive. So as medical personnel, we have the obligation, we have the duty of ensuring that our mothers go back with a live baby. Every mother that gets pregnant looks forward to going back home with a baby. Next slide. So what is the role? I know I put a neonatologist, but I want to put a disclaimer and say it's not only the neonatologist that takes care of the newborn baby, or that is supposed to be part of the multidisciplinary team. Any person that is skilled in newborn care in neonatal resuscitation is eligible and can provide or play the role of a neonatologist. So I want to say, wherever you're seeing a neonatologist, you can be the one. You can be the midwife, you can be that nurse, you can be that medical officer, you can be that pediatrician. You can actually be that obstetrician who is skilled, and you need to have a live baby. So the role is multifaceted. It aims to bridge the gap between prenatal diagnosis and postnatal care for a smooth transition for the baby and provision of ongoing support to the family. And that newborn care clinician that I have called the neonatologist should be at the forefront of advancing neonatal care and improving the health and well-being of newborns. What are the roles? When we relate to the case that was presented by Dr. Loro, we clearly see what is happening in our setting. So you that is solely responsible for the newborn, for this baby that is coming. You know, the obstetricians tend to look so much to the mother, and like actually Sister Southine has said, they will concentrate on the mother, but what about the baby? So the roles begin with prenatal consultation and planning, especially in high-risk pregnancies. And these have been already talked about by Dr. Amina and Sister. And then we assess the degree and the extent of the risk that is at hand. And after we have done that, then we counsel and educate the mother. And the previous presenters have made my work very easy. You know, sometimes as medical healthcare practitioners, we are overtaken up with the adrenaline that we cannot speak to the parents. We run around doing everything we are doing. And the mother or the patient that is in front of us is also scared, but they don't know what's happening. So Sister has hinted about, even when you have the late decelerations, what are you supposed to do? You need to speak to the mother. The other role is a multidisciplinary collaboration for comprehensive delivery planning. And again, this has been highlighted. The case we had this afternoon was a perinatal asphyxia. And the moment you flag and you're thinking it is an asphyxiated fetus, so we're thinking we're going to do a cesarean section. It could even be that you're going to do an assisted delivery. We need someone who is going to do immediate resuscitation. But if there is no one, what else? We also know this baby is going to end up somewhere. They are not going to follow the normal journey, the normal route. So that's why the multidisciplinary collaboration, very important. And then presence during delivery and delivery room care and resuscitation, including monitoring of vital signs and performing emergency procedures. And then after the baby has left the delivery room, the labor suite, the theater, then the journey in the neonatal intensive care unit starts. It many times is a long journey, and it's a journey of uncertainty. And then lastly, after the NICU, what happens as they go back home if they happen to walk the journey and go back home? Next slide. So we'll go through each of those things very fast. Prenatal consultation and planning, especially in high-risk pregnancies. I will not talk about them, they've already hinted about them, but we need to know that every time there is a high-risk pregnancy, there is a role for someone who is skilled in newborn care. Every time you have a congenital anomaly, there is a role for someone who is skilled in terms of planning for that baby. Every time there is history, the obstetricians are better at this. If there is a poor obstetric history, there is a role for someone skilled in newborn care. And if there is an intrapartum risk to the baby, and one of them is the case scenario that we've had that was fetal distress. So if we are having hearts, we are giving every heart an opportunity and saying every life matters, then the consultation needs to happen and the planning needs to happen. We will see what the planning means, but the images that you see down there shows the multidisciplinary teams. It might be that immediately the baby is born, the decelerations are because baby has a congenital heart lesion, that we would want the cardiologist to put their probe there and tell us what the problem is. It could be that there's something wrong with the brain. It could be that there's something wrong in the throat. That we also want, it's not entirely the newborn care clinician that is the sole caretaker of these babies. Next slide. Then we assess the risk. And again, this has already been alluded to by the previous presenters. And this involves understanding the extent of the risk to the fetus and planning accordingly. And this planning involves preparation for the delivery. It involves resuscitation in the delivery room. It involves preparing the room so that we have a thermoneutral environment. It involves what kind of respiratory support we would want to offer to this baby when they are born, or we are anticipating what might need to be offered. And then coordination of care in terms of after the delivery room, baby has been resuscitated, but they still need continuing care outside of the delivery room. Can we have the assessment to know, okay, this baby is going to go to the newborn care unit or the NICU. We need to prepare space, bed space for this baby. We need to prepare the respiratory support for this baby. And if there are other things that we know about this baby, including anomalies, do we need to alert the surgeons? Do we need to alert the cardiologists so that the baby receives the optimal care from the time they come out of the uterus? And then as we do the risk assessment, we coordinate the interventions as newborn care clinicians. Who is coming in first? What is our priority? Even when you have your diaphragmatic hernia, we are not going to call the ped surgeons and say, take your baby, because this baby with a diaphragmatic hernia may be having raised pulmonary pressures, which need to first come down before they can put a knife there. So we take that decision to coordinate and manage the baby from the beginning. Risk assessment, counseling and education. Again, the previous presenters, told us every mother that comes, gets pregnant is saying there is a baby on the way. And the entire family is anticipating and looking forward to that new baby, to that new life. And what is happening? The surveillance, the scan will show something different. And what is happening as they come for delivery, things begin taking a different direction. So these parents need to be counseled, especially about the complexity of the condition, and discuss possible and imminent challenges, prepare them for the arrival of either baby that will need support and long stay in the NICU, baby that will need intervention, a prognosis that might be guarded. These parents have a right to know all this before the baby comes. And that's why they need to go through the counseling and education. And then after that, where are they going to go? The next role is the multidisciplinary and comprehensive delivery planning. Just self-explanatory as part of the explanations that I've already given. It's a multidisciplinary collaboration for comprehensive delivery planning and involvement of all other disciplines as needed by the baby's condition. Delivery room attendance, care, and resuscitation. Again, this has been talked about. I'm happy that Sister Salfin has clearly stated that every midwife is skilled in newborn resuscitation. And I am happy about the syllabus and the curriculum in our country. But as newborn care special clinicians and caretakers, we need to be also present and get to be involved. So we do direct delivery room resuscitation, And like the case we saw, unfortunately, we don't know what happened in the delivery room. Not much of it was given to us because there are bits that we needed to know about, including the details of that resuscitation process. Then we provide the care from birth, which includes thermoregulation and warmth and other emergency procedures. What are those procedures that we talk about? It might include ventilating the baby from the time they are born, because you're not achieving the breath within the first minute, or providing any other respiratory support other than mechanical ventilation. It might involve having to provide for IV access, and because baby is asphyxiated, it might not go very easily, so it might involve accessing it through an umbilical vein or having to do an intraosseous. But in doing all these things, the monitoring of the baby should continue in the delivery room, even as the resuscitation process happens, because we know that baby who is asphyxiated is affected in totality. So the aim is to ensure we get adequate oxygenation and we get to that breath. That is very important. And then lastly, in the delivery room, we want to provide all the other necessary intervention that are needed. That pic there shows one of the modes of respiratory support, which every unit, it is not, I think it should be legal. It is abomination for someone to have a theater, an operating theater, where you deliver mothers and you do not have oxygen access for them, because you do not know when things shall go in the wrong direction, and you need to provide respiratory support even before you transfer to the next level of care. So it's something that we need to attend to. Next slide. The next is the NICU care. The NICU care is comprehensive care, and it's multidisciplinary, involves many teams. It continues with what has been started in the delivery room, providing respiratory support, parental support, and education, because the baby's condition keeps changing. Treatment of infections, hemodynamic support and stabilization, management of birth defects, and coordination again of other specialized care to ensure comprehensive care and the best possible outcome for the infant. I've put that as one of my slides that I'll talk about even as I end my presentation. Many times as we talk about perinatal asphyxia, we forget what is happening to these families after they have moved to the hospital. And like I've said, perinatal asphyxia affects the baby in totality. When I'm speaking to students, postgraduate students, I usually tell them, we want to look at the brain, because anyway, the brain is a vital organ. But asphyxia affects every vital organ. It affects the heart, it affects the intestines, it affects the liver, it affects the kidneys, it affects the mesentery, it affects everything. So if it's affecting everything, if your kidneys are supposed to be producing urine, so what is going to happen? It means there shall be no urine. You shall have some AKI, because there is hypoxia down there in your urine or whatever. If it's going to affect the heart, your heart is supposed to be pumping, this baby's heart is supposed to be pumping oxygen to all parts of the body. And if the heart is hypoxic, then what is going to happen? The pumping ability is also going to be affected. If it's affecting the liver, what is the liver supposed to do? If it's affecting the mesentery, and yet this baby, we are saying initiate breastfeeding within the first 1 hour of birth, what is happening? The mesentery is hypoxic. So again, all these come back into the long-term injury that is going to happen to this baby. We look at the brain, and this baby is bound to get blind. This baby is bound to get hearing impairment or deaf, is bound to get seizures, might not develop neurodevelopmental impairment or delay. So when we do not do what we are supposed to do, then, and we do not play our roles efficiently and effectively, this is the picture that we are giving to the parent. The child we are seeing there is a child actually who could have presented like the case that they actually discussed with us. Is a child with cerebral palsy, which was a result of perinatal asphyxia. And we can see the child looks big. All of our children at that age should be running around, playing. We shouldn't be supporting them doing that kind of thing. And that is what this mother is going through. And for us as pediatricians, we end up with this long obligation of having to follow up these babies if they happen to go through the neonatal unit alive by doing long-term follow-up and care. We do developmental assessment. We manage chronic conditions. We coordinate with other pediatric specialists regarding the conditions of these babies. And then we provide other necessary therapy, which includes physiotherapy, occupational and speech therapy. And then we support in the developmental milestones. The role of the newborn care clinician is enlarging and evolving with time. And these are new things that are coming up that the world is taking on, and which I think as a country we should seriously consider. One of them is telemedicine, to be able to provide expert consultation and support to remote areas so that we improve access to improved or specialized neonatal care. The other is how do we merge or integrate genetic and genomic medicine and the information we get from these things into neonatal care to better understand what is causing the picture that we are seeing in our neonates. And then research. That should be my last slide. I want to end by saying that every breath should be alive and they should thrive. And that begins when the pregnancy is realized and it is surveilled, and that fetus is coming, is monitored and prepared for, and every stakeholder is involved in doing the right thing to ensure it is not just living, but thriving. Thank you very much.
Thank you very much, Dr. Lloyd. This is indeed very timely, and thank you for diving us much more closer into what we should think about next when our babies are getting or having deviations in utero. I'm going to take two questions. If you have a question, just put your hand up, and then we'll move on. Okay, so feel comfortable to continue typing in the chat. Feel comfortable to continue typing in the chat. All right. Our post test should be running. Our post test should be running. Please do answer those questions. And we are coming close to the end. I would like to invite okay. I'm going to request our experts, starting with Dr. Amina, who is online, to just give the brief closing remark about what she has presented and anything else. Dr. Amina?
1 minute.
And we
Yes,
are giving you 1 minute, Dr. Amina.
I may use less than a minute. Thank you, Judith. And thank you for the opportunity to give these final remarks. I would just want to say to all of us that when a mother comes to us in antenatal care, it is of great joy to ensure that at the end of this journey of 9 months, that this mother goes back with a live baby who does not need to go and see Dr. Loy or be in Dr. Loy's neonatal intensive care unit. Like the baby she has presented, it is very painful for a mother to raise a child where she has to give up on every aspect of her life and just be there to take care of the baby who has come up with cerebral palsy. Therefore, much emphasis on intrapartum fetal resuscitation. Take care of those mothers when you are monitoring labor and be able to intervene timely to avert them getting from these consequences that cannot be reversed. Thank you so much.
Oh, sorry, I think the voice was muted. So as I was saying, this mother had planned her pregnancy, unlike many pregnancies that happen in our settings. But then we end up giving this mother a child with HIE, which is, I think, might be our fault by delaying to diagnose the malposition, which was first in this case. So I think we need to be taking more care about this mother's perinatally and also in the last trimester to ensure that things like malposition, malpresentation don't lead to such bad outcomes. So I would encourage all the medical workers, the midwives, and also all of us to be able to take care of the mothers in the last trimester much better. Thank you.
Yes, thank you, Dr. Loy.
Thank you once again, everyone. 1 minute. I want to receive babies that should be given our green card. The green card is the neonatologist should just come in and say, I am doing the routine newborn exam, and I am doing it on a baby that is normal, that is not asphyxiated, that is being given a green card to go and breathe, live, and thrive. Every heartbeat. We can keep those mothers away from becoming para-teens if we give them live babies. Thank you very much.
Thank you, Dr. Loy. Yes, Alvin.
Thank you very much. This is for the midwives. As a midwife, I'm just emphasizing that get to know that you are the eye openers for the rest of the caring teams, and know that your contribution, you are a decision maker amongst the teams that are present on that very day. You are not left behind. Actually, you are the team lead as a midwife because you have many hours with the mother in labor. And kindly religiously monitor this mom and interpret results. Interpret your findings and report timely and insist on timely action. Ensure zero separation of midwife and mother Please remain in the delivery room as we monitor this high-risk mom, especially the non-reassuring fetal heart. Have resuscitation equipment ready and functional, and ensure that you have the skill to resuscitate. If you don't have, start today looking for those skills. Involve the mother caretaker in the management. Reassure this mom because she has anxiety and arise the anxiety of both mother and the caretaker. Document all your findings for spot and future reference. And for doctors in this session, respond timely when you are called upon by the midwife. Otherwise, I thank the organizers of this webinar, the Global Ministry of Health, and my fellow experts. Thank you very much.
Thank you very much. Experts, and thank you for sharing your knowledge with us. At this time, allow me to invite our commissioner, Dr. Mugai, to give his closing remarks. Dr. Mugai, you are most welcome.
Thank you, Chair, and to all our presenters. Thank you very much. I could not make it at the time we are beginning this session, but it also gave me an opportunity to listen in very carefully on what was being discussed. And I really want, first of all, to appreciate the presenters, Sister Twinomahanji Safina. Your presentation was really very grounded, and it spoke to a really primary health provider. How I wish this would cover as much as possible in terms of our primary providers at those primary levels. Dr. Loy, thank you very much. Those were very good presentations. And you should not get tired. The best thing you can do for this country is teach as many people as possible to care for these small and sick newborns. We at the Ministry of Health, we are very excited to partner with SEED Global Health to ensure that we deliver these information and knowledge packages to our primary responders, our healthcare workers, to ensure that they are well capacitated to offer quality health services to both the mother and the newborn. I was more interested, and then I think Dr. Loy kept talking about it. We are not only looking at the mother to survive or the baby to survive, but we are going beyond survival. We are going beyond survival. We are looking at a mother who survives and thrives. We are looking at a baby who survives without any deformity. It is not okay to deliver a baby and the baby survives, but lives as a vegetable or with a cerebral palsy or with an abnormality that's probably iatrogenic caused by our healthcare system. It is not okay for a mother to survive, but she survives with a life-deforming abnormality. So in most of these things, we do offer, because we are chosen to do this work, we do this work with the spirit that we need to save both the mother and the newborn, not only saving them, but also giving them, restoring their life, like they should not have any other abnormality. So that is very critical. And thank you, Dr. Loy, for emphasizing it. As I was thinking through, I scanned through some local maternity and neonatal system, one of the innovations that we are pushing through. And I saw on one of the platforms, a beneficiary of good care was appreciating her doctor. I think it must be the Ankole or Mbarara local maternity and neonatal system. Said, my doctor always gave me time. I had a risk pregnancy. My doctor demystified my fear to the extent that I felt very comfortable. This is the type of care we want to give to our people. These are the kind of outcomes where we can guarantee that we shall do our ultimate best. God being our helper, we shall do our best to make sure that we give you a baby and also give you a life. This is the only gift, more than a salary, more than a thank you, more than a whatever bribe, that you can ultimately receive and say, yes, I did a good job. When you hear, I think the nurses and midwives have it in their anthem, something like "Hold my hand until something." I don't remember very well. But when that mother calls you my doctor, this is my doctor, this is my midwife, this is my nurse, there's no better experience, no better feeling than that. So we want to encourage our frontline healthcare workers. Traditionally, we have not been trained to communicate well. Even when a mother gives birth to a deformed baby, please, she's very traumatized. We've not been trained on how to manage. We don't have psychosocial workers. We've not been trained to manage mothers who deliver deformed babies or mothers who are extremely stressed. Pregnancy alone is very stressful. Intrapartum care is very stressful. Now the mother delivers a baby who is having a challenge, an abnormality, or birth asphyxia, or a premature, more stress. We need to have a very intentional package, and our team, SEED Global, we need to have an intentional package that we need to deliver to our health workers, because they are not trained in this. They are trained to do normal midwifery, abnormal midwifery, but who takes care of the abnormal part when there is loss or there is a disability? So we've not been intentional to do that. So as we move ahead, we've been seeing, I'm sorry, my closing remarks are like comments. We've been seeing, and this is very quick now, we've been seeing some issues that we think can be addressed. Again, I listen to a number of midwives, I talk to them, I see what they post. There is a growing tendency of midwives relying on the ultrasound scan. The ultrasound scan did not come to replace you as a midwife. Only refer to the ultrasound scan results after you have done your examination, after you have taken your history, if you've done the examination, and the ultrasound scan comes in to support what you are seeing, what you are feeling, and what you've had. That is the practice of medicine. Documentation. There is a challenge with documentation. Colleagues, we live in an environment where documentation is just a must. It's imperative. We need to document adequately. Quote the time. All midwives, by virtue of their training, are supposed to have a watch, this watch that counts even second, so that you are able to count. It is by purpose that you are supposed to have that watch when you do your vital signs. Vital signs are no longer vital. Midwives are not documenting. So, and that becomes an issue. When court issues come up, and they will definitely come up because we have so many lawyers trained with no jobs, they will come up and they will definitely affect our midwives. We don't want to be on the wrong side of the law. Let's do our best to do documentation. People are paying a lot of money. They're even having baby shower, bridal shower. There are many showers now. So that cost. Someone wants a good outcome of care at any cost, because there are so many showers. So documentation, I've left that one. We are also seeing a challenge in our primary healthcare workers not being able to interpret results, scientific interpretation of results. You are seeing a normal blood pressure, but the pulse is going high. You're seeing a normal blood pressure, which is physiologically explained, that the blood pressure can remain normal as the body is trying to compensate, but the pulse is telling you that this mother is bleeding. It is not okay to have a live baby with a dead mother. It's also not okay to have a dead mother with a live baby. Either way. So we must be intentional in making sure that we must have both outcomes good. During our MPDSR, we see 50% of all stillbirths are a fresh stillbirth. So it's 50-50, 50 macerated, 50 fresh stillbirth. But as far as I recall, majority are actually fresh. This means simply a mother came with a fetal heart into our care system, but lives without a baby, an outcome of pregnancy that she really wanted to have. So it's important that we continue to support each other. If you have a gap in taking the fetal heart rate, please, we can help you. If you have a gap in monitoring, any kind of monitoring, please, we can help you. But there are so many issues around acute. As a government, we are committed to provide you with in-service training. We commit to provide you with online sessions like the one we've just had. We commit to give you physical mentorships, which are targeted. If there is a gap, we shall definitely help you. We also have simulation labs now. We are going to set up simulation labs. We want to improve access to life-saving commodities. Caffeine citrate is already in our care system. We have surfactant, and we are going to take it as low as possible. We want to use evidence data, and we are also training specialists like neonatologists and neonatal nurses. So with all this package, our goal is one: let the mother survive and thrive. Let the baby survive and thrive. We are going to continue with these sessions. We've worked out an arrangement with Seed Global Health, and we want to ensure that I like where the frontliners, the midwife, Safina, people from, next we want to hear from Moroto. We want to hear someone from Kabale. We want to see someone from Kisoro passionately presenting. So we want to hear what they are doing. Where can we help them? We are available to help. And please, we have built a multi-sectoral platforms at regional level. If you are stuck with something, please post. In medicine, the more we all have the same uniform answer, the better. But when we all have different answers, we must implement things to standard. Emphasize, I think Dr. Loy, you'll take us next time, and this is my last point, would want to hear more about the golden hour, that golden hour that we need to do everything possible to make sure that we get a good outcome. But also we are thinking of explaining to midwives more about the fourth stage of labor, the fourth stage of labor. The textbooks might talk about 3 stages of labor, but the fourth stage of labor, that part of monitoring after the delivery of the placenta, is not over yet. The first 24 hours, that's when we are getting the most maternal death. The first 24 hours, that's when we are getting the most neonatal death. So it's not over yet when you have the third stage of labor completed. There's a whole monitoring, and we've been very explicit on training you on how to monitor. Every 15 minutes for the first 1 hour, and every 30 minutes for the second hour. After that, you are safe. You are safe. You're almost safe. You're almost there. More than 90% safe. So, colleagues, I want to thank the funders. I want to thank Seed Global Health. I want to thank all of you who have participated. It's been a wonderful 2 hours, time well spent. And to your convenience, you can even make suggestions. Even if you feel we can do this late evening when you're off your work, we are still capable of doing that. We want to do this at your convenience. We want to make sure we save as many babies and mothers as possible. I continue to insist babies and mothers because you cannot separate the two, and they must move together. Pediatricians, they must get that reorientation, that mother and baby together all the time. And I think very soon we shall also have the obstetricians attending such meeting. Thank you so much for the presentation. And I think officially I can close this meeting. Or am I supposed to close? Chair, am I supposed to close? So those were my closing comments. I can't hear you. So colleagues, thank you very much. If this was intended for me to close, the meeting is officially closed. The webinar. Thank you.
Thank you.
Thank you.
So you ask people to, you ask them to try.
Thank you.
Thank you very much. So as we are ending, can you kindly turn on your videos and we see who we had? And thank you. And we take a group photo. my God. Yes.
Yeah.
We can see you, and this is beautiful. The IT specialists are telling me they can take a group photo. So please put your videos on. We are seeing you, and this is great, and this is great. Thank you. So we are still taking a group photo. Woo! The group photo is done. Thank you.
Thank you.
So much.
Thank
you.
Welcome. You can leave at leisure.
Yes. What do you think?
What was that? Everybody?